we know that risk of recurrence with this disease is not only risk of recurrence from the tumor that was resected, but also late recurrence because you leave behind a sick organ that is pre-malignant, so to speak. And so the standard of care right now, I think, for most of us after resection is observation. And in this study, patients got atezobev, I think 17 cycles, about a year. Is that right?
Yeah, so we gave 17 cycles or 12 months of atezolizumab and bevacizumab or active surveillance. So essentially getting imaging every 3 months after surgical resection. And that's kind of what we do typically is every 3 months of the first year to 2 years. So the switch was the goal of giving it 12 months is, as everybody knows, there's a bimodal, this thinking that there's a bimodal recurrence following surgical resection or ablation in this patient population, where the first kind of peak is within the first 12 months to 18 months, and then the second peak is around 2 years. So we were trying to get over or kind of in the curative sense, the patients who had micrometastatic disease, at least at the jump, but not really looking to try to cure folks at 2 years or longer.
And since patients were disease-free, they were resected, then the primary endpoint is recurrence-free survival. And the news was in AACR in the publication, the study met its primary endpoint at an interim analysis. The study was stopped. However, with longer follow-up, things changed. Can you give us a little background on that?
Yeah, so when, as every trial, you have to put together kind of an interim analysis or kind of the stopping. And the first interim analysis actually met its primary endpoint. So the hazard ratio was 0.72 with a p-value of 0.012, demonstrating the benefit of atezolizumab and bevacizumab with recurrence-free survival. We knew going into it that likely OS or overall survival would not be positive, and that was because we allowed crossover, as most adjuvant trials do. We allowed crossover after recurrence. So folks who were on active surveillance and had recurrence were actually allowed to either get atezolizumab and bevacizumab or further curative therapy. So it was going to be unlikely that we would ever demonstrate an overall survival benefit. In the initial readout, the concern was there was nice separation of the two curves up until about 18 months. And then the curves started to have some sort of crossover. And so our concern is would this actually, upon further follow-up with more events, actually still demonstrate that atezolizumab and bevacizumab was significantly kind of better or showed an increased signal versus active surveillance.
So where there were no new safety signals, right? Atezobev performed as expected from other trials. So where does this leave adjuvant treatment as of today?
Well, it's as further follow-up, the curves actually did cross. So the interim recurrence-free survival benefit was not maintained. All of a sudden, the hazard ratio went from 0.72 to 0.9, even though it was just descriptive in nature for analysis, it wasn't maintained. So as of right now, adjuvant therapy for HCC shows no benefit at all.
Was there any groups that maybe got a benefit?
Yes, when you look through the forest plots, the recurrence-free survival was really consistent across all relevant subgroups. However, there seemed to be a signal in patients who were what we call outside the up to 7 criteria. So either the number of tumors or size of tumors greater than 7 at least had a signal for atezolizumab and bevacizumab giving improved recurrence-free survival. Obviously, the trial wasn't powered for this. However, when you look at the Kaplan-Meier curves for the recurrence-free survival, there was nice separation, and the separation really was maintained throughout. So it calls into question is did we pick a group of patients that were higher risk, or the high risk patients, so to speak.